Dr. Stephen Krieger is a professor of neurology at the Icahn School of Medicine at Mount Sinai in New York and a multiple sclerosis specialist at the Corinne Goldsmith Dickinson Center for MS. I learn something new every time I speak with Dr. Krieger, and it's great to see you.
It's great to see you. Thanks again.
This is a busy meeting for you. You're reporting the 3-year results of the phase 2 open label extension for Frexalimab. So can you tell us what Frexalimab is?
Sure. So, there's been a lot of attention paid to other disease mechanisms and treatments in MS in these last few years, such as BTK inhibitors and CAR-T therapies, but sort of maybe hiding a little below the radar is what Frexalimab does. It's an anti-CD40 ligand monoclonal antibody. So it's a monthly infusion. Takes about an hour, and it modulates the CD40 pathway, which the hope is it will regulate both active inflammation in MS, the inflammation that causes relapses, and also this more chronic innate immune processes that we think are responsible for progression. And so what I presented at this meeting is the 3-year extension after their phase 2 trial. So, long-term data, like long-term follow-up from a trial is always important, especially with a novel mechanism, a drug that we don't have otherwise. There's no other one. So the only data we have for how do people with MS do on Frexalimab for the long term is this extension trial. So this was the 3-year extension, and the punchline is people did not have new lesions, they did not have new enhancing lesions, they did not have new relapses. EDSS, so disability, was stable across the board. And perhaps most distinctively, compared with other things in our field, Frexalimab doesn't deplete cells. It doesn't drop the immune globulins over time. There doesn't seem like a cumulative negative consequence on the immune system with it. So all that is holding steady at 3 years. And no new bad news, no new adverse events of any note. So it's a good report. That open label extension keeps going. And now it's into phase 3 trials, one for relapsing remitting MS and one for first with secondary progressive MS. Those are ongoing. We've got about another year and a half probably before we'll see those results.
Keep our fingers crossed. This sounds exciting. Thank you for sharing those results.
My pleasure.
You're also presenting on the needs of individuals with advanced MS, specifically preserving function, reducing symptoms. The term advanced MS is a term some of my listeners may understand, but it isn't a term they often hear. You talk about progressive MS. How do you define advanced MS?
This is a great question. That was the opening portion of this program, was how do we define advanced MS? This was a course led by my dear friend and colleague, Rachel Stakem. Rachel is a nurse practitioner in MS in New York. She works at a program called Independence Care Systems, which endeavors to help people with disability live full lives, live in their homes, not have to be in institutional facilities, etc. So Rachel's been my close friend in MS for 20 years. We both got into this field together. But her career commitment is to people with significant disability. Let's put it in the terms. Folks who are wheelchair defined, users power devices for mobility. And in MS, we focus so much on preventing disability, which is a noble goal, but we're actually focused on it too much. Most of our clinical trials don't include people who can't ambulate. Most of our clinical trials don't include people of advanced age. And so there's been a blind spot in some ways in our field for the people who have developed real challenges from their MS. So that's what we mean by advanced MS. In essence, significant disability. But she points out at the beginning of her course, and I was just a speaker in her course, but she points out that there is no consensus definition for advanced MS. And without that, there is less of a sense of how big that unmet need is. What are the needs of this population? Population that moves along. And so one of the things she'd like to do is help to move forward a consensus definition, estimate the size of the population, survey what their needs really are, align resources to meet those needs. But the theme of her course was, it takes a community, it takes an interdisciplinary team, which is very much aligned with the spirit of CMSC as a conference, that no one provider, certainly no one neurologist, can get all the needs herself. But it is our responsibility to look for them and recognize them. And my principle that you may know that I talk about, but is very much a part of this force, is find the good people. Look for the opportunities to do something for them. And to remind clinicians in general, neurologists in particular, that there's never nothing I can do for you. There's always something. And we need to lean into it, listen carefully, think about the person in her way, and help her navigate her life and optimize her life, and not just prevent disability, not just treat symptoms, but be very holistic and proactive about it. That's what Rachel's course was about. That's what my talk was about.
You know, I'm very familiar with that world. Till she passed away, my wife lived in that world. And I would only add, not only is it, or it should be, neurologist, a specialist, responsibility to see that and to respond to it. When that doesn't happen, I'll say as a patient advocate, it is a patient's responsibility or their care partner's responsibility to advocate for it, to point it out. And I can tell you from personal experience very often, the answer is, I wish there was something I could do for you. I've heard that out loud, and my response was always, there probably is.
Yeah.
And I had some notes ready for that meeting. So we can't fix everything, but what here can we fix? And what I used to do with my wife is, what are the biggest things that are burdensome to you every day? And so it wouldn't just be a list of stuff, but it would be organized by priority. And that way, it increased the chances that one of those things could get addressed, mitigated somehow.
And I realized as I was saying it how resonant this is going to be for you. And this whole course, it was myself, Elaine, and Renee talking about mobility, talking about access, symptom management, people out of the hospital, and extending life, making it meaningful. The course was recorded. Not everything at CMSC is recorded, but Rachel Staten's course on advanced MS was recorded, so I do think it'll be available for folks that watch you and listen to you if they want to hear about it. I found it very meaningful. I hope we get to do it again, but at least this one was captured by CMSC on video, so it's out there if folks want to see it.
Well, I'm glad. I think folks at CMSC recognized this was something that should be shared, so I'm glad it was recorded. So you'll understand immediately where this question comes from, but when someone is living with advanced MS, how important is managing the emotional well-being of their care partner?
Yeah, well, when you talk about thinking about someone in their life with MS, a care partner, care provider, pillar of support, an awfully important part of that person's life and navigating. So it is with shared decision making in MS, but how about just shared values, shared well-being, and the sharing of that between care partner and physician, nurse practitioner, and occupational therapy, physical therapy, psychosocial support, social psychology, psychology. I think these things go hand in hand. And when we say there's always something we can do, there's always something we can do. And it's about finding who that person is to provide the support for the person living with MS, for the people living with them, supporting them. When one leg of the chair falls off, the whole chair falls.
Oh, good. I can only share with you that there was actually an occasion I would go with my wife to all of her appointments because, very often her neurologist would say, so how have you been doing? And if she had had a pretty good couple of weeks, she'd say, oh, everything's great. And I might add, it is, but remember 3 months ago, you couldn't get out of bed that day. And so I think what I used to say is, we're fighting the same war. We're in a slightly different foxhole. I'm not living with the disease, but does it affect everything in our shared lives? Of course it does. I once had a neurologist would walk into the examining room, see the both of us, and say to me, "I barely have enough time to talk to your wife. I don't have time to talk to you." So he hasn't got the memo, but hopefully he's in a shrinking minority. I will say that he picked a bad thing to say. My response was, well, she's been nonverbal for the past 6 months, so you have plenty of time to answer my questions. Yeah, there are those moments that, don't get featured all the time at these sorts of events. And unfortunately, the people who perpetrate those sorts of practices, they're never at these conferences.
They often are. And that's an awful moment and it has endured for you, but I'll just add a layer to it, which is to say, it was probably an honest comment on his part, because doctors and other healthcare providers are getting so squeezed for time from all sides. And so I shouldn't have said it. Well, we also shouldn't be so damn squeezed. Because
couldn't agree more.
We're trying to be present. So even the good ones are getting it cut from both sides and having less and less time afforded to them to spend with their patients, to listen to their care, etc. So, yes, no one should ever say it out loud, though. It'd be even better if we weren't in that position where it's the voice in our heads when we're with patients. I don't have time for this, and we need to.
To your point, I heard at this conference somebody say, yes, and there are all these things that are hard to get into that 30-minute appointment. And I thought to myself, that's a 30-minute.
I'm lucky in that respect. I'm at Mount Sinai MS Center. The Corey Goldsmith Dickinson Center's whole purpose was to try to afford time and space and resources and personnel. But it's very hard. And we're philanthropists. Because if we were trying to keep the lights on, keep the place going by just seeing patients, we'd also have only 5 minutes to spend. And we can't do right by somebody knowing how much you care if you don't have time to deliver.
One of the topics either being discussed or underlying discussions at this meeting, they are the latest iteration of the McDonald criteria.
I've heard about that.
That is the criteria used to diagnose MS. And although you aren't speaking on that topic directly at this meeting, you recently had a commentary published in a peer-reviewed journal where you shared some concerns about the most recent update to the McDonald criteria. Now, the updated criteria significantly lowered the barrier to a formal MS diagnosis, meaning patients can be diagnosed much faster. At least that is the stated goal. Sometimes after just a single anatomical lesion, if specific biomarkers are present. So in your essay, you raise a cautionary flag about this leap in diagnostic sensitivity. Historically, every time the McDonald criteria are relaxed to catch MS earlier, there's a corresponding surge in misdiagnosis, often confusing MS with migraine, small vessel disease, or neuromyelitis optica spectrum disorder, right? How concerned are you that these new criteria will amplify that misdiagnosis epidemic in non-MS specialist clinics?
How much time have you got for that? It's a couple of things. I think that the motivation of the McDonald criteria is to allow for MS to be diagnosed or believing what might have been missed. So I applaud the principle. Challenge, I think, is a couple of fold. One is the one you raised, that if we're going to diagnose multiple sclerosis, people who've never had a symptom of it, we have very little evidence of it on traditional MRIs. It does open up the risk of overdiagnosis. Someone who has a non-specific brain swelling, and misdiagnosis in general, confusing the disease for something else. I do think that's a concern. I also think there's a concern more deeply that we're saying someone who has a certain marker has a disease. That's opposed to saying someone who has a certain marker in the blood, spinal fluid, or even on a brain MRI has a risk for the disease. Those are two very different things. So I think we've confused the two. Someone having a risk for having a disease might merit closer monitoring, maybe even new treatment to prevent things from happening. That's what we've called radiologic isolated syndrome, RIS, all these years. It looks like MS on a scan, but the person has nothing to show for it. But in certain circumstances, these new criteria, and we're going to diagnose those folks with MS. And I think that there's something really risky about doing that. Telling people they have a disease that they may never have. They may never develop for their whole lives. Telling them they have it. So I wrote this letter. It touches on some other things, which maybe we'll get to. And the authors of the McDonald criteria wrote a response to my letter and a couple of other letters. This is in Lancet Neurology. So the journal that published the criteria. Which I'm pleased that this letter got there. A lot of people writing about the McDonald criteria in all sorts of places, but the fact that I wrote something that is critical and the journal that published the criteria itself saw fit to publish it is gratifying to me because I think raising are important points. But the responses from the authors to my letter was, we're doing this in Alzheimer's disease also. You know, there's biomarkers in Alzheimer's disease. Now we're able to diagnose that. That's actually very controversial. And a lot of folks are very unsatisfied or unhappy about that too, because many people who have these biological markers of Alzheimer's disease are never going to develop that either. So I think although they appeal to that as an example, I think that's a cautionary tale that we have now waded ourselves into in the MS world. And I do think it's a setup for error. And it's not fair either to people living with uncertainty, to people who've had an MRI scan. So that's one of my concerns. I've got a couple, but that's one.
We'll talk about another set of concerns. The updated criteria rely heavily on cutting edge. Checking for a select 6 threshold, a central vein sign, on mapping pearls, PRLs, measuring kappa-free light chains in spinal fluid, or evaluating optic nerve involvement by OCT.
Yep.
Now, these are all advanced imaging techniques and lab assays, routine at academic settings for the most part, or at least available in most academic settings, but they're rarely standardized or available at a local community neurological practice. How do we prevent these criteria from creating really a 2-tier diagnostic system where patients are going to be staged and treated based on their zip code?
Yeah, I mean, I think this is the biggest concern that I have. And I wrote about this in the commentary. I posted it on LinkedIn, my only social media, and there was a whole conversation there about that, including the 2-tier system concern. I'm no Luddite. I like technology, and I like new science, and I do think the field needs to advance. But the problem is, the criteria were written by folks who've studied these techniques for 10 or 20 years. They live in that world of cutting-edge science, and they've promoted those things into a diagnostic criteria, which the whole point of it is to be globally useful. Useful to general neurologists, broad spectrum neurologists in practice, useful to neurology residents and fellows who are training people in billing communities, people in under-resourced areas. A diagnostic criteria that's global is supposed to be a bar that everybody can achieve, so that every patient, every person who may or may not have MS can have that question answered. But by promoting these very specialized tools and techniques into the criteria, even though they kind of couch them as optional if they're available, I do think that it's going to make it essentially impossible for broad spectrum neurologists in the community, in practice, in training, to apply these criteria to their patients. Impossible. You said these techniques are available in academic centers. I probably smirked a little bit. We don't have them. I've never seen a pearl. I've never seen a central vein sign on a tiny scale. because we don't have them available to us at our well-resourced MS center. We don't have them. These criteria were announced in fall 2024. It is summer 2026. We don't have them. Many places don't have them. Now, I'm not saying we can't get them. We can get them in research. This is a thing I think that the community doesn't know, and maybe even the authors of McDonald underappreciate. It's not just you bring in a new imaging technology, now the answer's on it. That imaging technology needs to be ready for prime time. It needs to be standardized. An institution or an office needs to purchase it, install it, implement it. Train the radiologist to read it. It's not just pop up on the screen and says, this is MS. It's a technique. It's like art appreciation. You have to learn how to read what is a pearl, what is a central vein sign. I'm afraid that not only are these techniques not available to people making it to a tiered system, some have and some have not, but it's going to cause new forms of error. People misreading these things, misreading an OCT scan and saying, well, this person has optic neuritis. You can't diagnose optic neuritis with OCT. So I'm concerned that we're going to not only delay diagnosis, because patients are going to wait to try to find a place that has these resources. It's going to shunt MS diagnostic workup from everyone, every neurologist, to only the specialized few, which is going to make the wait times longer. We just talked about how people don't have enough time to spend with their patients. The wait times might be months, might become years. So the criteria, as you said up front, intended to expedite, make the diagnosis earlier, sooner, faster. I think it's going to delay it because it's going to make the wait time for people to get to specialists who know how to navigate these criteria longer. It's going to delay the diagnosis it was intended to expedite, and it's going to cause new etiologies and error. New mistakes on top of the old mistakes, but not correct any of them.
One of the things I wondered about with some of the advanced technologies being promoted as part of the criteria is not only that people might get it wrong, and not only that in community office settings they're not available. It occurred to me, community neurologist who reads that and just says, oh, this is not for me.
I give up. I give up. I wrote underneath there that general neurologists will be hamstrung. And that's a loaded word, but I think it makes it not for them. And I don't know that that was intentional on the part of the McDonald criteria authors. I just think that they live and breathe that stuff and forget that everybody can, not everybody does. So my thought is, you know how an operating system for a computer, they add features. You add more features, and after a few years of the development cycle, I think it's so complicated, it doesn't work very well anymore. It slows the whole thing down, doesn't run on your computer anymore. And then the next iteration of that operating system strips out all that stuff, they start over clean. Right? A clean, new, fresh operating system, getting rid of all the noise that got added. I would love to see a version 2 of the McDonald 2024 criteria. A revision. A cleaned up version. Strips away a lot of the unnecessary things, gets back to basics. Cleans it up, makes it doable by anyone. And then we can bridge this gap from where we are to where we want to be with new technology. But it's bogged down in a way that I do think is going to cause a lot of people to put up their hands and say, this disease isn't for me anymore. I don't understand what the MS community wants from me. And I think that does a real disservice to people, especially in under-resourced areas. I think it's going to worsen inequity, how healthcare is delivered in MS, which we don't need.
Sure don't. I feel like we've just been given a master class in contemporary issues in MS care. Dr. Stephen Krieger, I want to thank you for all you do to improve the lives of people living with MS. Thank you for sharing your clear-headed thinking so transparently. Thanks for talking to me today.
It's my pleasure. And listen, people can disagree with me on this, so this is my own perspective on it, and I'm okay to be wrong. I would like to be wrong about this last part. My hope is maybe the uptake will be faster than I realized, and these new MRI sequences will be easier to interpret than I realized. And we'll look back on this and think, Krieger underestimated it. I hope I'm wrong, but let's see.